So we had 3 challenges with 218, the filing. One was the NCCN. The second, we'll talk about it in a minute, how bevacizumab now works in neoadjuvant, because that wasn't included. And then the third was, is this really just a high-risk opportunity? So patients with stage 4 large volume residual disease, because that might be where the biggest benefit is, at least in ICON 7. So let's, the first thing, is it going to change your practice to get it FDA approved?
You know, it will change the practice, and there's a lot of regional differences between the approval of Bev in the upfront setting.
Yeah.
And so we have a lot of trouble getting approval for Bev in the upfront setting.
Payment, you mean?
Correct.
Yeah.
Correct. That's a good point. Payment for these drugs. So in those patients that I want to give Bev, and you just already identified those high-risk patients, large ascites, large volume disease, potentially extra-abdominal disease, okay? In those patients, I will utilize Bev. In the past, I wasn't able to.
That's interesting. How about you guys? Is it going to change your uptake?
I would say, you know, one of the things the answer is yes. And the other thing I'm excited about is we saw the translational science from GG218. JNCI paper was, I think, quite interesting, looking at microvessel density and tumoral measured VEGF-A levels.
Yeah.
And I think if we can actually get these biomarkers to help aid us as clinicians, yes, it's suboptimal, yes, there's ascites, you know, we kind of are all guessing right now. We need help here to really figure out which patients are going to benefit most.
So the FDA approval and the NCCN upgrade from 2B to 2A will make the reimbursement simpler. Will it change your practice?
Yeah, so I think, you know, right now, when patients come to us with newly diagnosed advanced ovarian cancer, they have a lot of choices. So, I mean, these choices are increasing sort of almost every few months. You know, they have at least 5 potential clinical trials to participate in, when they've got, you know, kind of layering in of PARP and immuno-oncology agents. You know, our group still uses intraperitoneal cisplatin chemotherapy at 100 milligrams per meter squared based upon GOG 172. We've got the HIPEC data, and now there's you know, the use of bevacizumab. So I think, you know, as a group within Dana-Farber and the Brigham, we will have a discussion and really come up with logical treatment plans for these patients. And in some patients, we're going to be discussing all of these different options.
So let's try to be very practical here. So let's say you decide to do IP. Does that include Bev?
So based upon 172, when using the 100 milligrams per meter squared of cis, no, it did not include Bev. So I would not include Bev in those patients.
And how about when you do weekly? When you do dose dense weekly, does that include Bev?
At this point, no. I think based on the studies that we have, you know, what we saw is the benefit of weekly is in those patients that are not getting bevacizumab. So I feel like that's a question mark there, where are we going to do weekly therapy, or are we going to add bevacizumab?
Well, I would take a bit of exception to saying those benefit. That was a sub-analysis, a
Absolutely.
very small population
Absolutely.
of patients in one trial. We now have 3 negative trials looking at dose dense.
Yes.
So with regards to that, the utilization, again, I think the question on dose dense or weekly paclitaxel is actually over. We should be using every 3 week in these patients. If we're using every 3 week, in that scenario, Bev may provide other benefit. Again, I want to identify patients who are going to have the maximum benefit of that, and the sub-analysis on ICON 7 identifies a subgroup of patient. Again, the European component of that trial, of those trials.
So we don't use IP chemotherapy in Phoenix, but we do agree with you that weekly's over.
Yeah.
At least for now. I was initially an advocate of weekly, even here on Onc Live. I think weekly came and went. It's an every 3 week world, whether it's every 3 week IP, whether it's with Bev. I think that's an interesting point.
I would say the caveat on MITO 7 for our more frail patients, using a weekly strategy of an AUC of 2 of carboplatin with Taxol at 60 milligrams per meter squared.
So when I say weekly, I mean dose dense weekly. When paclitaxel is given weekly, you can dose intensify. But if you give it weekly, since it's better tolerated, you can just give fractionated. So you can drip in the chemotherapy, as I say, an AUC of 2, right?
Dr. Monk, weekly dose dense Taxol is not better tolerated at 80 milligrams per meter squared.
I said weekly is better tolerated. And so when weekly is better tolerated, you can dose intensify. But at equivalent doses, it's better tolerated. So AUC at 2 and paclitaxel at 60 weekly is better tolerated, and that's
that
the
I would
MITO
agree.
7.
It's nice for our
So,
elderly
but that's
patients.
not dose dense. That's fractionated.
But I mean, there's one particular situation that I will still use carbo AUC 6 and weekly paclitaxel, and that's the very ill neoadjuvant patient who comes in
Yeah, I
lots of
get you.
ascites, is super sick, and I want to see them. I
Yeah,
want to
that's
see them
fine.
every week.
I think that's a good.
Ursula, I
And
thought
it's
you were gonna-
equivalent, but other than that, I agree that I am an every 3-week
Okay, thank you.
carboplatin paclitaxel.
I was hoping you were going to say when you're giving chemo in Japan.
That's right, exactly.
Because
The Japanese, right, the
strong
JGNG, yes.
supportive trial was in Japanese women. But again, it takes 2 trials to convince me or more of anything. And this idea that the weekly idea has not been substantiated, and the HIPEC needs a second trial, to our point. So, but we have 2 trials of bevacizumab, like you said, GOG 218, ICON 7 published at the same time. So again, in trying to figure out who the best patient for bevacizumab is. So I said we have 3 challenges. One is reimbursement, and NCCN and FDA will approve that, help that, improve that. Then we have this idea of, is it just a medication for what you said, ascites, liver mets, or is it all comers frontline?
So I would say that I think 218 clearly, and again, as we see more survival data that comes out from ASCO, does support, as long as the FDA will give us an approval, does support the use in certain patients, bevacizumab. ICON 7, I think ICON 7 for the intent to treat population, the overall survival difference was not different.
Right.
And in that second paper from Amit Oza, the progression-free survival was also not significant between the 2
There
groups.
was some
Again,
significant-
granted, it's a different dose of bevacizumab, though.
You mean it's a non-placebo controlled, right?
So many
at
different
the
issues
wrong
with that,
dose,
with the wrong dose.
for too short of a time.
That's
that
right.
study? Oh, I can.
I think that may be slightly overstated. The half-life of Bev is probably adequate at
it's
that dose, but I
reasonable.
think in the approved dose at 15 milligrams per kilogram every 3 weeks is what we should be using.
Correct.
But generally in antibodies, like cetuximab, we give a loading dose. So if you're going to use 7.5, then at least load them. I don't know. It's not evidence-based.
But no data, clearly no data to
Yeah.
support that last statement.